Whenever you're ready, Commissioner.
All right. Well, good afternoon, everyone, and welcome to the Tuesday, April 25th, 2023 meeting of the Zuckerberg San Francisco General Joint Conference Committee. We'll call to order, and Secretary Morowitz, will you call the roll?
Sure. I'll start with you, Commissioner Green.
Present.
Commissioner Christian.
Present.
And I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you. And I should mention that Commissioner Chow wasn't able to be with us today. So the next item on the agenda is the approval of the minutes of March 28th, 2023, and I believe we had a very minor correction on the minutes.
Yes. Thank you to Commissioners Chow and Green for noting on page 23. Let me just quickly go through this. There were some minor edits, and it's all under the medical staff report. I'm going to state the revised language, which is posted online. Dr. Day stated that the issue is more that space is needed for outpatient service. Currently, these procedures must be done in the operating rooms. This relates to ophthalmology procedures, cataract. And then under Commissioner Chow's comment, he noted he was questioning about outpatient clinics. And the revised statement says, Dr. Day stated that the biggest impediment was infection control because not all regulatory measures were able to be provided in the current setup of the ZSFG outpatient clinics. That is all.
Great. All right, is there a motion to approve the minutes?
So moved.
I will second.
All right, so I believe we have somebody on the line. Let me just make sure that I get public comment requests. All right, anybody on the line who would like to make public comment requests for this item, please press *3. I do not see any hands, Commissioners, so I'll take your motion. Actually, I'm sorry, we're in the new world. You have to both say
Right.
and all in favor.
We will, all in favor, say aye.
Aye.
Okay,
Very
great.
good.
Would you like to call or would you like me to call?
Why don't you go ahead?
Okay,
Yeah,
great.
that's great.
Item 3 is the Regulatory Affairs Report.
Hello, Emma Moore, Director of Regulatory Affairs. So to give us an update pending surveys, we do not have any major updates other than a date correction on our Joint Commission window. So that does run into 2024. In terms of our survey activity, we have 2 noted here. So one was a complaint investigation done on March 3rd by CDPH on 4A, the skilled nursing facility. And since this report was generated, I'm happy to report that we have gotten that complaint was unsubstantiated. So the complaint was related to the discharge process, and again, it was unsubstantiated. And the second visit there was from Cal OSHA, related to a facility reported workplace safety event in the birth center, and documentation review is in process, and there has not been active movement on that at this time. We have not submitted any plans of correction during the March process in which this is being discussed. We'll have more details about the stroke Joint Commission Plan of Correction next month. And in terms of our facility reported events, you can see that there were 8 reported events in the month of March. So 4 pressure injuries, 3 privacy breaches, and then 1 other, and that was the power outage that occurred on March 21st. And so overall, that brings our total for the year to 14, and over the 3-year period that we are reviewing, we are at 134 reportable events. And lastly, in terms of plan of correction monitoring, we have 1 plan of correction monitoring data to bring forward to the committee. And so that relates to a pressure injury plan of correction from a pressure injury that occurred last May. And the remaining monitoring item that is due for reporting is regarding our policy. So the policy was past its 3-year review date as required by Title 22. And so our audit is that we've been looking at 10 policies per month until we reach greater than 90%, which is actually 100% required. We will be reporting on this for a bit. I am happy to report the initial data was that we were at 60%. In March, that moved to 70% compliance, and we're now up to 80%. So this is something we are actively working on to move forward, and we are hopeful that by July 1st, by the fiscal year, all policies will be in date, and we will be able to retire this monitoring. With that, I will open it to any questions.
Thank you. Is there any public comment on this item?
Folks on the line, if you'd like to make comment on this item, we are on item 3, the Regulatory Affairs Report. Please press *3 to raise your hand. I see no hands, commissioners.
Right. Any questions?
None for me.
Okay. I guess I only have one, which is, what do you think the barriers are to hit your 90% compliance on the HOPI plan of correction? Because it sounds like you're making great progress, but sometimes, I mean, if it's like a remodel, it's that last 10%. I'm wondering, if there's anything in particular that just stands out on your punch list, shall we say?
I appreciate the remodel analogy, because that is in many ways what it is. So in January, approximately a third of the administrative policies were past their 3-year review date. And so we have, I think, 70 policies in February and March have come through the committees for approval. So there has been much work being done on this. And so we just kind of have the last stragglers that are going through the approval process. And again, there have been some transitions and some other things that have been happening, but we are confident that we can have all of the policies reviewed by Joint Commission and Title 22 requirements. So I think at this point, I don't see any major barriers that we need assistance with. I think collectively, the ZSFG team has done a great job of rising to the challenge of when we've identified, hey, we need to do this. You can come back and make it pretty later, but we need to at least make sure that we are reviewing these actively, and the team really has risen to the challenge. So again, I am hopeful that you may hear one more of these reports where I say that we're around 80 to 90%, and beyond that, it will just be reporting that we're at 100. So thank you for the question.
Well, thank you so much, and thank you for you're always so enthusiastic and positive, and it's greatly appreciated.
Thank
All
you.
right, we will go to the next item, I guess.
Yes, great. Item 4 is the ZSFG Chief Executive Officer Report and Emergency Department Newsletter.
Good afternoon, commissioners. Susan Ehrlich here. Commissioner Christian, it's wonderful to have you back with our committee here. I think this is the first one you've been to for a while, so I'll be going through things that I think are very familiar to Commissioner Green, but please feel free to stop me with any questions or anything that doesn't make sense.
Thank you, Dr. Ehrlich. It's good to be back.
Great. So first of all, I just want to say we've changed the format of our report a bit to recognize that we're now in the endemic phase of COVID. So we're not starting with COVID anymore. We're starting with quality, and it's really nice to report that we had a successful opiate treatment outpatient program survey back in March. This program is really remarkable because we just celebrated its 50th anniversary, and that's 50 years of leading the way for best practice treatment for substance use disorder and opiate addiction in particular. So it's really nice to be able to celebrate them, especially with this lovely photo here. We have had a couple of events related to COVID since we last met. First, and quite symbolically, I think, we closed our vaccine clinic, which has been open and active in various spots on campus, though, since almost the very beginning of the pandemic. And it's worth noting that that clinic, that team, which was so dedicated and creative and flexible, provided over 21,000 Mpox vaccinations and over 214,000 COVID vaccinations for the community under very challenging circumstances. So there is also a lovely picture of them, and it's really nice that, it's really nice to celebrate them on this big change in practice. The work that they do is being incorporated into our various clinics on campus and in the network. So that's how we're moving on. And then we have had a change, a small change in our masking guidelines. We still wear masks here on campus and in clinical areas. In places on campus where no patients ever venture, we do recommend still, but masking is optional. And I suspect that we'll be, revisiting these policies as we go forward. But what we're doing is pretty much in line with what other hospitals in San Francisco are doing. We tend to be on the more conservative side, which is fine, especially since we're seeing continued outbreaks of various types in the community. In our equity section, we have a section on Black Maternal Health Week. This is a really important topic because in the United States, we have the highest maternal mortality rate compared to other high-income nations, and Black birthing people are 3 times more likely due to die with complications of pregnancy and birth. I'm very proud of the work that we do at ZSFG, even though it's often difficult at times, it's also very rewarding. And there's a long list of things that we're doing here to improve our birthing rates. So I wanted to call that to your attention. And we have lovely profiles on the next page of one of our midwife providers and one of our patients. We have a new person in leadership who is here on the call, Angelica Jernigan. She is our new Chief Administrative Officer. She is filling the spot that Kim Nguyen used to be in until she left us almost a year ago now. I'm really thrilled to have her here. Now you can see her. It's lovely to have her. And Lisa Winston is going to be transitioning. She is ending her term as elected Chief of Staff, and she's going on to start a new position of Associate Medical Director of Med-Surg starting on July 1st. This is an incredible opportunity for all of us because Lisa has a wealth of knowledge about the work of Med-Surg and in particular our strategic flow work, our safety work. And so having her move over into that position is really quite fortuitous for all of us. And then we have a variety of healthcare recognitions. Social Work Month, National Doctors Day, Patient Access Week, and then our own Ayanna Johnson being recognized as one of Becker Healthcare's 50 Chief Experience Officers to Know in 2023. So on these lovely pieces of news, I will pause and see what questions you have before I move on to the data.
Well, first of all, it is so nice to meet you, Ms. Jernigan, and we'll look forward to working with you. This is a wonderful team, and Dr. Winston, we will really miss you and hope we can come up with some excuse to have you report to us. There must be something about Med-Surg that will have to come directly from you, I'm sure. And then what a wonderful honor for Ayanna Johnson. That's just fabulous. So I guess we should ask for public comment for starters.
Because the report's not over, we'll wait till the end.
Wait
Yeah,
to the end,
so just-
okay.
Yeah.
Any questions?
And I do want to mention Dr. Gabe Ortiz is also on the call, and he is the new elected Chief of Staff. So he's here orienting and transitioning into the role, and so you'll see a lot more of him as time moves on.
Wonderful.
All right. Moving on to our data. So
I just wanted to say briefly, welcome to our new doctor. It's really wonderful, director. It's really wonderful to have you. And it's good to be back, as I said to Dr. Ehrlich. And I also just wanted to comment on, the reports that you have, the nature of the work. Once again, the opiate disorder treatment, that clinic, 50 years, it's amazing. And the work that you're doing is never been more necessary, obviously. So it's just, we're so grateful for that work. And also the work that is being done for Black maternal health, and where you're focusing on things for pregnant women, for birthing people, and the underlying stress that all Black people, and not only Black people, but specifically Black people, the weathering that has been documented and researched for decades, that women of color and people of color go through, and on a baseline, and then maternal health and birthing risks on top of that. So thank you so much for the continued focus on this work and the great results that you're getting. It's so important. Thanks.
And of course, I have to add to that very articulate comment, because it's only places like the General that are going to be able to lead the way in maternal health. There is such a crisis in this country, and it's heartbreaking as an OBGYN to see what's going on and to see the potential we have to backslide because of some of the recent legislation in states around that are Republican dominated. So I am so delighted by the work you're doing, and I hope you will continue to give us updates and publish, because it's the results you have and the wonderful people. It was so wonderful to read these profiles. They're going to help others that are really being hand-tied by legislators and certain cultures to help lead the way to try to get us through some of the recent, almost inconceivable barriers. So very much appreciated.
Well, thank you so much for those comments, both commissioners. It's really important for us to know how well supported we are, and quite honestly, we just couldn't do the work we do in these areas that are really important and often controversial without your very dedicated support. So thank you for that.
I just want to add, I recall probably one of the last meetings I attended, there was an update about how the system and the hospital was preparing for what might come politically with respect to healthcare access. And at the time, it was a visionary preparation, but it was also, kind of stunning to have that assertion and that realization made so clear, because I think even then I didn't really fully accept the idea that we would be where we are now in this country and in most of this country, that people cannot get the health care that they need, and they're going to be dying as a result of it. So once again, just the community is so fortunate to have the leadership at the hospital and in the system that we have. So thank you.
Thank you. Yes, it's very sobering to think about where we are, but I know I am, and I know we are all grateful to be in this place where this work gets supported. Okay, COVID. So on page 8 of the report, you see our really beautiful graphical displays of where we are in the pandemic. And as I was considering this 7th surge, the things that are a little bit different about it is it's kind of bifurcated and it's quite wide. And that may be characteristic now of the endemic phase of the pandemic. What it feels like here is sort of a continual low-level presence. We are today in the green, a surge level green, meaning that we have fewer than 10 COVID positive patients in the hospital, and it's been that way kind of for quite some time. So COVID is present with us. We have lots of policies and practices to support patients with COVID, but it's neither as high as it ever was nor as low as it ever was. So we're sort of in the middle with that. Moving on to our emergency department data, you can see both in the daily volume and in the average daily admissions, not only are we busy, but we are very busy and full with patients who are sick. So you can see our average daily volume is as high as it's ever been at 184. And it's leading to a very high number of average daily admissions, meaning that the patients who are coming are sick. So 36 is also a high number of admissions. And there's a lot to say about the impact of that on our organization and in particular on the people who are here. On the flip side of that, I'm really proud and happy to report that in spite of these very high volumes, we've been working very hard on some of the things that can go wrong as a result of very high volume. So on page 10, you can see that our leave without being seen rate is coming down with a focus on improvement. It's still not at the best practice where we'd like to be, which is about 2%, but it's definitely come down pretty nicely as a result from the 10% where it was earlier in the winter. Similarly, we've been coming down with our diversion. You know that we're under a plan of correction from EMSA, At the present time, we need to be under 50%, which we are. And eventually the standard is for us to be less than 30%. There are a lot of things that have made these things possible. I have to say probably the most important thing is that we're well staffed in the emergency department right now. And we can talk more about that, but that is one of many things, but probably the most important thing that allows us to achieve these goals. Moving on to other things that are most different in the med surg area, you can see if you move on to page 16, you can see now that that the volume we just talked about in the emergency department being reflected also in the med surg unit, right? So 197 census, you can see that actually goes beyond the capacity of our physical beds. And you might ask, well, how is that possible? How can we have more patients in the hospital than we have beds? Well, it means they're placed in other places. Primarily, they're in the emergency department waiting and in the ICU waiting. So on any given day, we have more patients in critical care than actually are critically ill because they're waiting for med-surg beds. And then they're also in the PACU, and they have been scheduled for come and stay procedures. So that's what makes us so full. Fortunately, we can see our intensive care volume coming down. That's likely, in reflection of a seasonal pattern, but it's still busy in the ICU. We still see a lot of very sick people, both on the medical side and traumas and injuries on the surgical side. So we're still really busy, but not quite as busy as we were in the peak of the winter time. And then moving on to page 19, sadly, we are still struggling with our lower level of care average daily census. And, recently, I've been trying to think about how to categorize this problem. And I think it's made up of, it's in three buckets, really. There are things that are completely out of our control. For example, the lack of affordable housing in San Francisco, which is a key driver of this problem. There are things that we can influence. So for example, access to shelter beds, which are controlled by other city agencies. And then there are things that are more within our control that we can try to influence, like access to case management programs that we run in the department. So it's a very, very complex problem. And, we're working on it as well as we can. I would say that this is the area where it not only is it a problem that is bad, because we've gone from, in April of 21, the total of 26 lower levels to now in March of 23, 72 on any average day. But, this is something that we'll continue to be talking about and working on. And I know Gabe in particular, because he's the medical director, he's the medical director for MedSurg, has a very keen understanding and interest of this. And the problem is also present in 4A, but not quite as bad. In psychiatry, we've had this problem for a long time. And it's gotten a little bit worse, but it's not, and it's the same factors sort of driving it with a slightly different variation. So from there, we've gone from 34 to 41. Moving on to our safety, you can see on page 23 our occupational health cases. It's also a reflection of our endemic phase. We're down in the 20s, say, of total number of people in the department who were managing under OC Health. So it's still present, but nowhere near as high as it's been over the years. And then workplace violence, you can see a slight trending down. I have to say we're still in a phase now where I don't think we can perfectly rely on the data quality, because we've just made this shift from the UO system to the SAFE system. I think that's going to be changing very quickly, and we do have one of our 4 strategic initiatives is focused in this area So we will be bringing this to you as a strategic A3 presentation sometime in the next couple of months. So I'm eager to do that. I think that's the end of what I want to highlight for you, but I'm happy to answer any questions or defer those questions to my colleagues where appropriate.
Thank you. And now, is there any public comment
Yes,
on the report?
folks on the line, we are on item 4. If you'd like to make comment on that item, please press *3, the CEO report. I see no hands.
All right, Commissioner Christian.
Nothing.
All right, wonderful. Well, I would just, no comment?
No comment.
Okay, because I can't hear that well with this thing. I just want to compliment you on this incredible diversion rate and left without being seen or treated rates. Those are, as I said at our last meeting, I think beyond what we thought was possible given the complexity of the patients and the volume. And I think this is really incredible work. And certainly we respect and understand all of the challenges that are truly out of your control when it comes to the lower level of care situation. Do you feel that if and when Laguna opens up, how much would that really decompress these numbers? Because as you talk about other factors like housing, for example, there's these new mental health beds that are supposed to open, I'm not sure when, and on Treasure Island. But as you look at what's possible in terms of both available housing and the potential to be able to reopen Laguna, do you have any sense of where these numbers might trend? Would they go down to closer to where we were in 2021, or is there any sense of that?
That is such a good question. It's something we think about and talk about a lot. It will certainly help, but it will not be, it'll not solve the problem by any means. And I think that's twofold. First of all, the situation that we're in is after more than a year of not having admissions to Laguna Honda. So this is a problem that has built up over time. The second thing is, and I don't know a lot about the details of this, but I quite suspect that the patients we are able to refer into Laguna Honda once it's open may not be the same patients, meaning that we quite likely are to have less flexibility in the patients we send there. So I think there are still certain categories of patients we're going to have a lot of difficulty placing. And I think that's something that is definitely a problem for the network and the city to work with us on. There are patients with certain types of problems where there really aren't good options for, and that will be true even when Laguna opens.
Thank you. I can't think of anything else on this item. All right, well then we will thank you so much for the report and for all the good work.
Great.
And
I'm sorry.
Oh, go ahead. I'm sorry, Mark.
No, I want to make sure that we're good. Is it okay to move on, Commissioner?
Absolutely.
Okay, great. Item 5 is the hiring and vacancy report.
Good afternoon, Commissioners. My name is Emma Perez. I'm here with the HR Operations, the clinical team. So I wanted to go over the ZSFG Human Resources Services report. Our vacancy rate has decreased a little bit. So hospital vacancies decreased from 11.74 as of March, which is down from 12.50 in February. We've hired a total of 35 employees during that month in various classifications, including RNs, and 3 of those are separations. We had 3 separations during the same period. None of those were retirements. Some of the factors for the high vacancy rate include, as usual, our greater competition for talent throughout all of the hospitals and healthcare facilities, as well as the labor force's uncertainty about layoffs and hiring freezes. Our RN vacancy rate has decreased to 10% this month, and we continue to work closely with our hiring managers to take advantage of our training candidate pools. Our most popular RN training program is used to fill the med-surg, peri-op, and psych care training positions. And our RN recruiter works in tandem with nursing leadership to really go after students in their last semester or recent graduates of nursing programs to grow those candidate pools. To mitigate some of those challenges in hiring, we've hired 5 P103s to fill gaps. Hiring managers continue to strategically use different selection processes depending on the size of their candidate pools. We had an event in April, and that event was very successful. We had a great turnout with all participant slots filled. Participants got a chance to tour the hospital. They had dedicated time with nursing directors to learn about the different positions throughout the department, and they also received assistance from HR on their applications, hiring process, any questions that they had. As you may have heard last month, we are still working with the city performance unit at the controller's office on HR process mapping to map out the entire process and see where there's streamlining and standardizing that we can do to help make improvements, and we'll keep reporting back on any improvement recommendations. HR still meets with the hospital executive team or program managers to review hiring plans. And as far as the RN hiring update for experienced positions in emergency care, we have 3 experienced positions with selections pending right now. In critical care, there's 4 vacancies with 3 selections made with start work dates in April and May. For Med-Surg, we have 27 experienced vacancies with selections pending. The OR, at the time of this report, didn't have any vacancies, but there's a lag in systems, and so they really have 2 vacancies right now. So they're in the process of making selections for those. For the training update, our critical care training program is anticipated to start on May 13th with a cohort of 6, and then the next one is scheduled for October 2nd with a cohort of 10. The emergency care training program is anticipated for July 24th with a cohort of 10, and our Med-Surg training program is targeted for April 29th with a cohort of 6. And another cohort in June. And some of our non-RN hiring highlights, we've hired an 0931 Chief Administrative Officer, 2325 Nurse Midwife, an Assistant Purchaser, a Health Program Coordinator, and 2 Medical Social Workers.
Great,
and that's our
thank you.
report.
Thank you. Any public comment?
Folks on the line, we are on the HR report, which is item 5. Please press *3 if you'd like to raise your hand to make comment. No hands.
Yeah, congratulations on the progress that you're making in filling these vacancies. It's so difficult, people in the community outside of the profession, hear and read all the time about the lack of candidates and qualified candidates with the degrees necessary and the training in this field. And so, and I know how hard the department has been working on it for the past couple of years. And so I just want to congratulate you on the work and the success that you're having.
Thank you.
Yes, I would echo that. And, I was wondering if you could clarify. I know there was a job fair, and I know there's some coordination ongoing for hiring nurses in general, considering both Laguna Honda and the general. What is going on at a systems level, and how do you view that as, helping your hiring efforts, or how do you view that in light of the efforts you're making?
Well, we are definitely taking a look at how we can be creative, and I think one of those ways is to do the RN events that, like the one that took place in April. So looking at how we can do those more frequently, and really, like I said, because it's so hard to find experienced nurses and to bring on experienced nurses, oftentimes to positions that maybe night positions and not so, geared towards an experienced nurse, that we're really targeting those training pools. So we're trying to grow our training pools. Again, we're looking at it system-wide to see if there's any flexibilities that we have in terms of how we're able to recruit nurse students, whether or not we need to actually wait until they are graduates, or if we can target them in their last semester, as well as making sure we're really focused on those candidates that are coming through the hospital to do their rotations or to do their preceptorships. So we're really trying to be creative about capturing those that have already had some contact with us and who already know, the flow of the facility and are very happy to come back and work for us.
And this is obviously a naive question, but does anyone, even an experienced nurse who's going to come newly to the general, have to go on night shift? Is that just mandatory?
It is. It's part of the negotiations in their contract that the shifts have to be the day shifts have to be prioritized with existing staff, and so they're really coming on to night shifts.
And is there any average number of months, weeks, years that people end up on night, for example, with your emergency room? If you were telling someone you only have to do this for X number of months, does that, you may not know, but is there any way you can give them some light at the end of the tunnel on this whole issue of being on nights?
I understand that there are actually some nurses who prefer night shift. So I'm not sure. I don't have any information right now on that. I can come back to you with more information, or I don't know if nursing leadership is on and can address that question right now.
That's fine. I just was curious more than anything. Thank you. And I actually have an anecdote. One of my patient's husbands used to work at Mills Peninsula, and he is now working as a psych nurse at the General, and he loves it, and he will stay there for the rest of his life. And he would be happy to step up and come to recruitment events and tell his story. So if you would like his name, it's HIPAA protected right now. If you would like his name. I mean, it was like 5 minutes doing her exam and like 10 minutes talking about the General. So I just had to let you know, it just happened this week. So he's very happy on this being a psych nurse there.
Oh, that's great. Thank you so much for sharing.
That was really wonderful to hear. Well, thank
Always
you.
good to have some positive external input.
Absolutely.
All right, thank you, Emma. And also, Emma had a difficulty getting the WebEx invitation. I hope that we get that worked out, and I'm glad to see you today, that it all worked out today for the meeting. Item 6 is the medical staff report.
Thank you. Hello, commissioners. It's my pleasure to be able to present the medical staff report to you today. We do not have a clinical service report to review today since one of the service chiefs for family reasons needed to defer. So we will be having that later. And we just have one item that's an update for privileges. And this is actually really good news. So as you are likely aware, in interventional radiology, there are a variety of procedures that need to be done that are vascular intervention procedures. And but the pool of people who can take call for that is relatively limited. And so at UCSF, they have some folks in their call pool who are actually neurosurgically trained, who have learned how to do these vascular intervention procedures and have been incorporated into the team of clinicians who takes call for interventional radiology. And we actually share call with UCSF across the campuses. So we have updated our privileges for interventional radiology for a couple of specific privileges: angiography, vascular intervention, procedural sedation, and carotid artery stenting. to include the prerequisite that somebody who has the appropriate neurosurgical training can also apply for these privileges. And I am happy to answer any questions about that if there are any.
So Mark, guide us through what we have to do, because this is first of all a recommendation for the full commission to approve.
Yes, so the action is now, Commissioner Christian, since you've been gone, the city attorney has advocated for only the full commission to approve policy. So at the JCC level, they're recommending the full they review, comment, and then recommend the full commission, and it goes on the consent calendar. So yes, so you all can make comments if you like and talk about the policy, and then the action that you two would take would be to vote to recommend that the full commission approve this at the meeting on May 2nd.
Great. Well, I would just say that I know how difficult it is to have individuals do these absolutely critical and time-sensitive procedures. I have a patient who's an interventional radiologist who did a case and had a baby 6 hours later because they really needed her. So I can completely understand, and I think this is a really smart way to try to expand this very necessary pool. So I certainly think this is wise.
Sounds like a very good move.
Now, do we need to do public comment or?
Yes, we do. I'm sorry, I'm taking notes. Folks on the line, if you'd like to make comment on item 6, the medical staff report, please press *3 to raise your hand. No hands, so the two of you can vote when you feel like it.
All right, so we should move to recommend these privileges to the full commission.
So moved.
And I will second that. And all in favor?
Aye.
Aye. Thank you.
That's great. Thanks so much. Let's move on to item 7, other business. I'll ask if there's any public comment on this item. Press *3. No hands. I'm not seeing any comments from you all, commissioners, so we can move on to general public comment. Folks on the line, this is a time to make comment on issues that are not on the agenda. Press *3 to do that. Okay, I see no hands, and now we're at a consideration for closed session.
All right. Is there a motion to go into closed session?
I move that we go into closed session as recommended.
I will second that. Is there any public comment?
Oh, thank you. That was even better. I completely forgot public comment. Folks on the line, if you'd like to make public comment on item 9, a consideration for closed session, please press *3. No hands.
All right. All in favor?
Aye.
All right,
Into
please
closed
give me
session we will go.
30 seconds. Folks who are on the line, you will not be able to see or hear us. We will be back. All right, thank you very much. Okay, we are back in open session. Public open session. Commissioners, please consider a motion to disclose discussions held in closed session or not.
I move that we not disclose the discussions held in closed session.
And I would second that. All in favor?
Aye.
Aye.
And now you are at a consideration for adjournment.
Move to adjourn.
And before I second that, I just want to thank Dr. Winston for all the wonderful work she's done, and welcome Dr. Lopez, welcome Ms. Jernigan, and welcome back Mr. Christian. And I will now second the motion to adjourn. All in favor?
Aye.
Aye.
All right, thank you, everyone. Have a good day.
Commissioners.
Thank you.